Well, hello and welcome to this month's podcast, where we're going to bring you up to date with the very latest information and data in rheumatoid arthritis. Now, joining me today are two fellow members of the IMID Forum Steering Committee. What a joy to have Professor Peter Nash. He is a professor of the School of Medicine and Dentistry at Griffith University in Brisbane and associate professor of the Department of Medicine at the University of Queensland. Busy man. He's also the director of the Rheumatology Research Unit at the Sunshine Coast. And my second esteemed guest, Professor Maurizio Cutolo, who is Professor of Medicine and Rheumatology, Director of the Research Laboratory and Academic Unit of Clinical Rheumatology, and Director of the Postgraduate School of Rheumatology at the University of Genova. I visited there recently for our wonderful European workshop, Maurizio. Bella. Fantastic. Thank you, and forgive my awful Italian. So, Peter, Maurizio, warm welcome.
Thanks, Ian. Lovely to see you.
Thank you, Iain. Welcome.
Right, folks. Well, look, today's podcast, we're going to review two papers that are investigating the risk of adverse events following treatment with a JAK inhibitor. It's a long-running story, this triggered, as we all know, by oral surveillance and, well, actually just our general vigilance as clinicians. But the first paper comes from Gert Boomeister and colleagues and looks at the long-term safety of filgotinib in moderate to severe RA. And then the second is from Adam Goldman and colleagues looking at a post-marketing analysis of adverse cardiovascular events with JAK inhibitors, again, in rheumatoid arthritis. And as always, folks, if you want detailed summary slides for the papers we're discussing today, pop along to imidforum.com. That's imidforum, all one word, .com. Okay, Peter, do you want to take us through the filgotinib safety analysis? Thanks very much.
Thanks very much, Ian. As you said, it's very topical, the question of JAKs and JAK safety. This is a paper from Annals of Rheumatic Diseases, April of this year, and it was looking at integrated safety analysis of filgo in moderate to severe RA and the treatment duration up to 8 years. So we're getting out there now. The median was about 3.8 years. So filgotinib, as everyone knows, has been approved in many countries around the world, not in Australia, unfortunately, and I don't think in US just yet, but European Union, UK, Japan. And previous studies have established the efficacy and safety of filgotinib using their phase 2 and phase 3 program. But this is really trying to look at comprehensive rheumatoid type safety in the light of the findings, as you've suggested, oral surveillance with tofacitinib and the RA Bridge RA branch baricitinib data coming up very soon. So this study looks at 7 clinical trials which were integrated to evaluate the long-term safety. So that's Darwin 1 and 2, which were the phase 2 studies, and the 3 Finch papers 1, 2, and 3 looked at MTX-IR, TNF-IR, etc., and their respective long-term extension studies. The one thing, it looked at the 2 doses, 100 milligrams and 200 milligrams, with durations out to 8 years, median 3.8, but didn't compare to methotrexate arms, didn't compare to placebo arms, as some of the other follow-up studies like the upadacitinib safety analysis that Boomeister presented at the EULAR Vienna did. So the AEs were monitored, they compared doses, and they split them into ages, less than 65 and greater than 65, given the EMA rules about over 65 and the use of JAKs. So they were monitored, categorized. They looked at AEs of interest, serious infections, malignancies, MACE, and VTE in particular. They did subgroup analysis for the 2 ages, as I've suggested, and helpfully, they display the results as exposure-adjusted incidence rates per 100 patient years of exposure. And that gives us a chance to think about, if we treat 100 patients for a year, how many of our patients are going to run into this issue. And when you looked at the exposure-adjusted incident rates for any treatment-related AE, the numbers were in the 110 and 96 type range, equivalent across the 100 and 200. But remember, most of those TEAEs are nuisance things like nasopharyngitis and headache and upper respiratory tract infection. And this analysis was through the COVID period, and they had quite a significant number of COVID infections that make the numbers look the way they do. So, but the grade 3s and the SAEs were numerically high with the 100 versus the 200. There's no dose response. There's no increase over time, which is always reassuring. And the ones that have special interest, like serious infections, malignancies, MACE, and VTE, were stable, as I've said, across the intervals. Filgotinib maintained a stable safety profile over long-term use. The rates of things like zoster were quite low in what we would expect. We'd expect something like 3 per 100 per 100 years in a European population, American population, up to 7 in the Asians. And they were getting zoster rates between 1.1 and 1.5. And I think that's an important message, that of all the 4 JAKs that we now currently have available, this one seems to have less of a zoster signal, and we can discuss that, why that might be. They had, they ended up following 3,500 patients for 12,500 patient years. There was non-melanoma skin cancer, 0.4 versus 1.4 on the under 65, over 65. Malignancy, about 1 to 2 per 100 patient years, a little bit higher in the over 65, as you'd expect. And there was a dose response across most of the AEs, 100 to 200. And the cardiovascular risk, for example, 40% in the under 65s, 75% in the over 65s going into the study. Small numbers on steroids. I worked out the number needed to treat to have a serious adverse event. It was about 17, but the treatment-related serious adverse events, the number needed to treat was about 63. So the bottom line really is that filgotinib looked like the safety was stable over time, no unexpected adverse events, no major signal for MACE malignancy or VTE, and a lesser signal for zoster than the other JAKs show, so that they support using either dose, but the lowest dose in particular in older patients, and being aware of those risk factors that the EMA has defined to individualize our patient choice.
Yeah, thanks, Peter. Succinct and crystal clear as ever, my dear young man. Thank you very much indeed. So, Maurizio, where do you put this paper in your mind against a whole range of other manuscripts that we've reviewed on the IMID forum over the last number of months? What does this bring us new beyond filgotinib, or does it sit comfortably with the ideas you already have about the safety profile of the JAK inhibitors?
Several papers are produced, of course, as you mentioned it, and even the paper I will report, if you want, right now by Goldman. This is a very interesting, because a large study, a surveillance trial post-marketing safety, showed an increased risk of major adverse event, cardiovascular adverse event. But in this case, only JAK kinase inhibitors versus TNF-alpha inhibitor were considered. In this very interesting retrospective, if I want study, where compare the 3 different kinase inhibitors with biological demands, and of course also TNF-alpha inhibitors, just to see if any difference between the different kinases concerning the MACE, the major adverse events, were present, even versus TNF-alpha. And what interesting, the first data concluded a larger number of patients, because almost 75,000 patients treated with the JAK inhibitors, tofacitinib 52,000, so the majority, versus 300,000 patients treated with other DMARDs, mainly were treated with tocilizumab and including also TNF-alpha inhibitors altogether, with a mean age of the patient of 60 years. So an advantage age that included some comorbidities and higher risk for side effects. And in particular, in both groups, the percentage of female was 80% versus 11%. So, as we know, in female, the risk of thromboembolism, for example, much higher than in men. So this may be high percentage of patients, female, like is in rheumatoid arthritis, but particularly high in this, the proportion was 80-1, tell us that this risk is increased. And what happened? When different JAK inhibitors were compared each other, the most frequent side effects was venous thromboembolism, stroke, and as well as other side effects like swelling, leg swelling that may be related to the major effects like thromboembolism. And this was particularly frequent with baricitinib and with upadacitinib, less in tofacitinib. In any case, when stratified by age category, all safety signals were statistically significant in patients aged less than 65 years. So it seems that this is a class effect. Such involvement of the cardiovascular system with major side effects seems really a class effect. Usually, such kind of problem starts during the first year of treatment. And this is another important aspect already shared with other studies, previous studies, and are confirmed in this study. But we can say that generally, we can say that venous thrombosis is the higher. At the end of the story was suggested to avoid the use of kinase inhibitors in particular situation. In particular, patient aged over 65, smokers, patient with previous problem of the cardiovascular system, and this is the three major contraindications to start kinase inhibitors. And this may be the most important final suggestion, result of this very large analysis, suggesting how and which kind of patient are rheumatoid arthritis patient that should be treated with kinases should be chosen. No great difference versus biological demand in any case concerning the major events when looking at this population at higher risk. I think at the end of the story, this large observational perspective, retrospective of the post-marketing study tell us really that the risk exists, but the risk is much higher if other comorbidity are present. So this is, I think, the real final message.
Yeah, thanks, Maurizio. And that has resonance for one of the most striking findings in oral surveillance is how few patients in the trial who should have been getting cardiovascular prophylaxis actually were not. So I think that final remark is sage. So look, let's take these two papers in the round. Peter, I'd like to bring you in first. I mean, the thing about post-marketing reporting surveillance is the huge risk of ascertainment bias or some variance that people were reporting this because they're worried about it. So what are your thoughts? How do we interpret these two studies?
I don't know what to make of this. I don't know what to make of this Goldman paper. I mean, selection bias, indication bias, notoriety bias, people putting in garbage in, garbage out. I just got a feeling I don't know what to make of the numbers because you can't work out an incidence. What's topical, people putting in reports and they get tired and they stop putting in reports. The second, third JAK doesn't get the same reporting as the first one. You don't put in any reports for a TNF because it's been out there for so long and all known. So I really find this paper very difficult to know what to do with the numbers because of all the selection, indication, notoriety bias issues. And they even say themselves the limitations and that this paper is hypothesis generating. Well, I don't think it really is. I just think it's somebody who's dredged up a very large cohort of patients. But coming back to one of the oral surveillance things, was a paper presented at this EULAR from the British Society of Rheumatology, which is a lovely paper that looked at the impact of the European guideline measures and how many patients who went onto a JAK would have had the risk factors and perhaps wouldn't have gone onto a JAK. And there was something like, what's the number? 80% met the at-risk criteria out of 1,300 people starting a JAK. That's how common it is for our patients. And something like 30% had already failed 3 biologics. So there was this great area of unmet need. These needed these treatments no matter what their risk was. And so, you know, I just think that age, cardiovascular risk, ever smoker, and increased risk of cancer, whatever that means, is surprisingly common amongst our patients. And we have to individualize our choice. Between you and me, I don't believe the lung cancer story. That was a quirk of that paper. There was 40 more smokers on the JAK side compared to the other side. There was 40 less ever smokers on the TNF side. And you only have to move 6 or 9 malignancies and you change the entire finding of that paper. So lung cancer, I don't buy. VTE, I wish I knew the mechanism. Is it a JAK2 effect? Is it a class effect? Because what's interesting from the Goldman paper, they had a lot of pulmonary emboli. And Dennis McGonagall's argument is that JAKs will cause thrombosis in the setting of infection. And that if you get a pulmonary infection, you'll get a thrombosis at the site of the infection, an unproven hypothesis about to be published. So I wish someone could explain to me, because normally when we see VT, we see a lot of DVTs, we don't see a lot of PEs. But with this story, there's a kind of a 50-50 of those two, which I think is unusual. So VT probably is real. There's a dose response, etc. The MACE, I don't know what to make of it. We've had so many real-world evidence studies that don't show an increased risk. From Sweden, from the Cora Vitas, from the STAR study, it's very difficult. And unfortunately, the FDA blanked every JAK based on one JAK and every indication based on one high-risk indication. So it's very difficult, and that has changed the entire landscape around the world.
Yeah, thanks, Peter, as ever, for your sage remarks. Let me just try and dissect this out. So, Maurizio, thinking about the filgotinib paper, do we think filgotinib is different from the other available JAK inhibitors, or does it sit just in the same box from your perspective?
But if you let me just spend a few words about the mechanism and why probably we observe such kind of side effects, especially vascular. We know that there are at least 400 different kinases inside the cells, and each one has a role. So it's an intracellular signaling that we are going to touch when we use the inhibitor, not extra, but intra. So, and the different cytokines are inhibited by the different kinases. Maybe someone inhibits the prothrombin, and other IL-10, and other the IL-1, IL-6. So we could expect many side effects, but related to the different kinases inside the same class. So, for example, it's clear that when some of the kinases, in this case, for example, baricitinib, interacts and with the receptors and alter the prothrombin action on platelets activity, it's much easier for the platelet lose their activity and induce thrombi. And this is something that you have with some kind of kinases that particularly inhibit prothrombin. Other inhibit much more pro-inflammatory cytokines. And so maybe the prevalence of side effects versus the others is different. So I think that it's clear it's the same class. The class effects that we know at the beginning already, we observed the problem of frequency of infections for inhibition, interferon gamma, interference with interferons, and so herpes much easier. And then malignancy, again, for trouble on immune system surveillance. And now, but already I saw that from 2015 already were signaled vascular, cardiovascular problems. That means after from the emission in the market of the first one, tofacitinib, already at that time was signaled the possibility of such kind of side effects. So I think it's not expectable in all the patients, the three major risks. So the increased risk of infection or development of malignancy that now is clear, in addition to the immune check inhibitors, increase the risk of malignancy from kinases, and now is evidence, also very evidence, for the major cardiovascular effect, but should be expected. So it's important, in my opinion, to well inform the prescribers which are the major risk factors that should be carefully controlled before to start the kinases, and then may carry one of these side effects. It's a question of, can I say, prevention of the side effects, in my opinion, because not absolutely must obtain these side effects, but it's high probability now, after 15 years of marketing, that will happen.
Yeah, so I think I'm taking
my 2 cents in, Ian. Just to say that I think all the JAKs are different, just like all the TNFs are different. They'll have different durations of inhibition of different cytokines through the dosing signal. And the malignancy thing, if you look at oral surveillance, TNFs had 3 times more prostate cancer than the JAKs did. They had 5 times more melanoma than the JAKs did. So I think none of this was statistically significant. There was numerical differences. And I don't think we should jump to conclusions based on oral surveillance.
So I'm loving this, guys. So pulling all of this together, first of all, I'm hearing strong counsel that the black box warning is there. We've been given an idea of which indications and which cautions need to be applied in clinical practice. And on this podcast, we're absolutely recommending that we follow those guidelines and advice, just to be crystal clear. That's, and I'm hearing that loud and clear from both of my friends and colleagues. Secondly, I'm hearing that we desperately need to understand the mechanism. And I think that actually the mechanism across the board, you can't help but feel that the mechanism around thrombosis ought to be discernible. The cancer issues are just going to be, immune modification in cancer. It's taken us 40 years of immune oncology to get to checkpoint inhibitors. I doubt we're going to solve this one in a few months, if I'm honest, around the oncology risks. The final thing, just what strikes me from Gert Burmester's paper is the difference in apparent frequency of zoster cases. And I think that's interesting because it does suggest that maybe filgotinib is doing something a little different. And that, I think, is the third thing I would say, just refreshing the message Peter's just given us. I don't think we should make an assumption that all JAK inhibitors are created equal. And that's going to become really important as we move into the, well, people argue about whether it's the third or the fourth generation, when we start to look at allosteric inhibitors and when we start to look at customized different kinase dual inhibitors, and those are all now in the pipeline with AI-driven chemistry. So look, I think the take home from this, as ever, fascinating podcast is more data. Differences, I think, what really important for clinicians listening to this, separate out different sources of data because they carry their own inherent value, but also their own attendant risks of bias. And we just need to be very vigilant as we look across, because we've got two quite different approaches to garnering data. And with that, folks, I am going to draw this podcast to a gentle conclusion. You'll notice, by the way, in the background that Peter has a beautiful village in the background, Maurizio, an elegant Italian office, and I have very grey hotel room in Manchester. And I'll let you draw your own conclusions about who's living the best, most charmed life of your 3 podcast years today. But with that, I'm going to thank Peter, thank Maurizio for your sagacity, for your wisdom, for what you brought to the knowledge base that we all carry forward in our clinical practice. And to you, our listeners and watchers, if you want to see the publications uploaded this month, and as ever, there's a whole lot of other podcasts and resources, head over to imedforum.com. Don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel and make sure you don't miss our podcasts in the future. That would be very bad to miss our podcasts in the future. We enjoy making them and we hope you enjoy listening to them. And as a sign of our faith, make sure that you let us know what you think by leaving a review. And as always, thank you for your attention. Wish you the very best of luck in your clinical practice, ever onwards to try and make the lives of our patients better. Thanks very much indeed.
Thanks, Ian. Thanks, everyone.
Thank you to all of you. Thank you, Iain. Thank you, Peter.
Thank you. Grazie mille.
A tutti.